Hi there, my name's Amy and I'm a breast cancer survivor. I created Calm Through Cancer to help women with early stage breast cancer build mental resilience so that they can move through treatment guided by inner strength and not fear. And one question that I've seen come up over and over again is, how do I know if a lumpectomy or a mastectomy is right for me? So I knew I wanted to create a resource on this topic, but then I thought, why not go directly to the source? So today we're going to be talking to Dr. Michael Grant. He's located in Dallas, Texas. He's a surgical oncologist who specializes in breast cancer, so he is really the expert on this topic. We're going to be talking about the key considerations that go into the decision-making process, and spoiler alert, it is often not a cut and dry answer. So because of that, I really want to encourage you to talk to your care team and your breast cancer surgeon about what might be best for your specific scenario. With that being said, let's go ahead and dive in.
It's a complex interaction between size of tumor, size of breast, and location in the breast. So this is different than colon cancer. Colon cancer is something you can't see. And once you do the surgery, it really doesn't matter what it looks like as long as it works okay, but this is the breast. And even though taking out the disease is primarily what our goal is, one of the things that we're always interested in is cosmetic outcome. And so the question is, can we do a lumpectomy and have a good cosmetic outcome? And that's a question that sometimes is difficult to answer just by looking at the surface, so you kind of have to dive into several different things. So first of all, there's the physiologic and then there's the emotional component to it. So let's talk about the physiologic thing. So the question is the tumor size such that when we take it out and we have a clear margin, something that when we're finished we have something that looks like a breast? And if the answer to that is yes, then I think lumpectomy is always a good choice as long as that's something that the patient's comfortable with. Almost always we add radiation therapy as an external beam to the equation to reduce the chance of the cancer coming back. So as long as the patient is a good candidate for radiation therapy and is accepting of that, and we can do the operation with a good cosmetic outcome, that's a good choice. It's almost always added when we do a lumpectomy. It's sometimes added when we do a mastectomy. Most women who have a mastectomy don't need radiation, some do, and some of that's dependent on the size of the tumor, whether the nodes are positive, whether the margins are clear or not. So those are some of the features that will sometimes determine whether radiation is necessary with a mastectomy.
Okay.
So the reason that most women get breast cancer is because there's one group of cells that start growing out of control, and we don't quite understand why that is. And the rest of the breast cells are normal. And that's why lumpectomies work well, because if you just take out the bad guys, leave the good guys behind, everything works out well. When you have a gene mutation, which is not present in the majority of the cases, it's only about 10% of the population that we treat with breast cancer, you have an abnormality in all of your breast cells, both sides. There's a repair mechanism defect, which doesn't allow the DNA to repair itself once it takes hits. And so you have an area of cancer, but taking care of that one area doesn't guarantee that the rest of the breast doesn't develop cancer in the future. And I don't have to tell you, but it's one of those issues that sometimes is difficult to face if you're going to be one of those people who potentially would have to face this again in the future, because they ain't fun to go through. If you think your risk is much higher in the general population of having to do it again, sometimes that makes sense to do something a little bit more radical at the very beginning to reduce the chance of having to do it, not just in the same breast that you've been diagnosed, but in the opposite breast as well. So you have to think about the operation as being effective at taking care of local disease, which is right here in the breast and the chest wall area. And if you talk about the difference between a lumpectomy and a mastectomy, there's a few percentage points different, but they're pretty close. So when you do a lumpectomy and add radiation therapy, it's going to be right around 6%. When you do a mastectomy, it's not zero, but it's a little bit lower. It's about 2 to 4%. And the reason it's not zero is because when we do a mastectomy, we can't move 100% of breast tissue. Even if you do a good mastectomy, there's still microscopic amounts of tissue which theoretically could form cancer later on. So it's a rare event, but it does happen. And so if if you look at the local recurrence rate, they're pretty close. As I said, just a few percentage points apart. Now, the other issue is survival. And survival is exactly the same, and sometimes that doesn't make sense because some people equate local recurrence with survival. So you can have a local recurrence and be treated successfully for it. It doesn't lead to an end of your life. So we're actually more interested in why that patient recurred as opposed to the fact that they recurred. Because typically we can almost always take care of a local recurrence. But the question is that a harbinger for disease somewhere else in the body, that you failed local treatment, not just locally, but also systemic treatment is maybe not effective at curing that disease. And that's what comes down to the survival aspect of it. People don't ever die from cancer occurring in the breast. They die from a complication of that disease going somewhere else in an important structure in the body that you can't live without, like your liver, your lung, your brain, something like that. And that event is really more dependent on the disease that we're dealing with, much more so than the surgery decision that you made. So again, we are effective at taking care of the disease by doing either. However, the survival is not relevant to how you treat a disease locally. Usually with recovery means I got to get back to doing something, whatever that something is. And so when you ask your surgeon that, it's important to put that in perspective, what the surgeon is trying to get you back to doing, to decide what that activity should be and when you should do it. So for instance, a lumpectomy typically is an outpatient procedure. You don't have to stay in the hospital. And most people go home the same day and are up and around pretty quickly. With some limitations on heavy upper body activity, medicine requirements are pretty minimal. A lot of people take pain medicine for a few days and maybe are on Tylenol and Advil after that. So recovery is pretty fast. Mastectomy, as you know, takes a much longer time to recover, and a lot of it depends on whether you're doing one or both, and also whether the reconstruction is done at the same time or not. Most of the time we try to do primary reconstruction, but the reconstruction sometimes add a complexity because the drains are necessary either way. Sometimes the drains stay a little bit longer with one versus the other. Most of the time when we do a lumpectomy, we don't put drains in. So working around the drains sometimes is a limitation with activity. You actually have more lack of energy with a mastectomy than you do with a lumpectomy. So getting your stamina back is a little bit more difficult, especially if you've been through chemotherapy up front. Sometimes you're kind of depleted already, and so you take a bigger hit at the very beginning. And so energy, maybe you can do a lot of things, but you just can't do it all day. So the energy is that. And then if you're trying to get back to some type of upper body manual type of thing, there's going to be more limitations with a mastectomy with or without reconstruction than there is a lumpectomy. Most people are healed and kind of doing their normal thing, got their energy back in about 4 to 6 weeks with a mastectomy with or without reconstruction, maybe 1 to 2 weeks with a lumpectomy. The question that we get a lot is, okay, if I'm going to decide to have a mastectomy, or let's say we need to have a mastectomy, what about the other one? We call removing the other one a prophylactic mastectomy, meaning that we're removing it not because it's got cancer in it, but because you're trying to reduce that risk somewhere down the road. And just like anything else, you got to know what you get out of it and what you don't get out of it. So first of all, most of the time, unless there's a gene mutation involved, the risk is not high. Most of the time, it's about 10 to 15% over your lifetime. And when you have the type of cancer that you're taking anti-estrogen medicine for, it typically reduces it by about half. So effectively, it's probably right around 5 to 7% for most people and most cancers. Gene mutations may be a lot different. It could be 20%, could be 50%, and so sometimes that makes a difference. So if you're having the discussion about risk reduction, obviously you get more risk reduction if it's a high risk as opposed to a low risk. And again, we can't make it zero. We can get it down to about 1 to 2%. So that's the first thing to point out is what amount of reduction do you get from that operation. The second thing is there's no survival advantage by doing that.
Yeah.
You don't live longer if you do it. And that's because, again, even though we are keeping the breast, whether you do one mastectomy or a lumpectomy, If you are in a screening program, you're going to catch another cancer early and you'll be treated successfully for it. So that doesn't translate to survival disadvantage, but again, there's some value potentially in that patient deciding that they don't want to go through treatment again.
Yeah.
And then the third thing you kind of pointed out already is when we rebuild a breast, it's not a breast. It looks like a breast, it does not feel like a breast, and our goal with that is that in a bra and a bathing suit, nobody can tell the difference, but it very clearly is not your own breast, and we all have to be okay with that. So most of the time, if we were dealing with the gene mutation and we're talking about a very high risk, most women will end up doing a mastectomy on both sides. However, if you don't have a high risk, it's still okay to make that decision as long as you understand what you're getting out of it and what you don't get out of it. You know, we say breast cancer or breast tumor, people always imagine we're dealing with this.
Mm-hmm.
Okay, so when we say cancer, you imagine there's like a ball in there, but sometimes there's a very early breast cancer, but it's more like a paint splash. So, for instance, you had an invasive cancer, which is more like this, but sometimes we're dealing with a non-invasive cancer. So it's an early breast cancer, but instead of dealing with this, we're dealing with a paint splash. And sometimes it's difficult for women to understand why they have an early breast cancer, but a lumpectomy is not a good option. And that's because the amount of disease which is spreading out in the breast and that paint splash pattern, when you try to do a lumpectomy, you're taking out so much of the breast that it doesn't make sense to do it because cosmetically it's not going to be appropriate.
Yeah.
So that's one thing that sometimes is difficult to understand for people who are trying to figure out, okay, so you told me I have an early breast cancer, then why can't I have a lumpectomy?
Mm-hmm.
Sometimes those are better candidates for mastectomy. You know, it depends on age. So if you're dealing with somebody who's less than 50, it's very common that they'll choose mastectomy, especially if they have young families, things like that, because the issue there sometimes is not so much that they think they're going to live longer, but they think they're going to live better, not having to worry about it or not.
That peace of mind aspect.
Peace of mind. So those are three words that I hear over and over again, peace of mind, peace of mind. So even if you don't have a gene mutation, sometimes it makes sense for people to do a mastectomy on both sides, just so they don't have to worry about going and having screening and having to face the possibility of having to deal with another breast cancer diagnosis. The other issue that's really common with young women is that they have dense breasts and they're more difficult to diagnose by doing screening. So let's say that you have a 35-year-old woman who hasn't been doing a mammogram yet. They find their own cancer. You do the mammogram, you can't see it on the mammogram. So how do we follow people after a lumpectomy? We do a mammogram. So sometimes people have a mammogram that's negative, and 3 months later they feel their mass. And then you go back and look at it and you go, well, we can't see it on the mammogram. Well, how do you see it then? Well, we can do a sonogram. Maybe we have to add an MRI into the picture. MRI is fine, except there's a lot of rigmarole that goes with that. There's contrast, it's expensive, has a very high false positive rate. And so sometimes the fact that they have a cancer that's difficult to see in the first place, and then screening on the other side is a very complex feature for their recovery. Sometimes they make the decision that they just don't want to deal with that. When you do a mastectomy, you don't have to do mammograms anymore.
Yeah.
So sometimes that part of it becomes part of the decision making. You know, you're dealing with a disease in which the patient has choices. So sometimes the patient is a really good candidate for a lumpectomy, but emotionally they're not there. So that's why I was talking about there's the physical part, there's the emotional part to it. Sometimes they're not a good candidate for a lumpectomy, but want to do it anyway. And they'll tell you, hey, I get it, I'm going to have a deformed breast, but I'd rather have that than have a mastectomy. And oftentimes you will see older women in that scenario because they don't want to go through the big process of doing a mastectomy without reconstruction. And they'll decide they will accept a less than perfect cosmetic result just so they can kind of get it out of the body and kind of move on with their life because the cosmetics are not important.
Yeah.
So again, there's a choice that people make, and sometimes the choice really is not a medical one, but it's really a personal one. And that's the important thing that I always point out to folks is your survival's the same, your recurrence risk is very close. What do you want here at the end of the day? Because you got to go home with this.
Yeah.
And it's not just what we can do for you here, but it's also what it means to you here. And that's a decision that sometimes takes a little bit of time to make. So that's why we ask folks not to make a knee-jerk reaction. Like you said at the very beginning, sometimes the knee-jerk reaction is, I want to have a mastectomy and do both while you're at it so that I don't have to worry about this, and also I want to live longer. And that's usually not the case. So what I usually tell folks is take a deep breath, step back, look at the whole picture, make a good decision. If you take a little bit of time and understand all those little features of it, you won't ever look back. So I find that the folks who have a support system, whether that's the family, the church, whatever, is really important. Folks who are going through this by themselves don't have that, have a much more difficult time, even with a lumpectomy. And as what you're doing right now, getting in touch with the community, understanding that you're not alone, that you can go through this and do fine and be normal on the other end of this is really an important thing to see. The surgery stuff, the chemotherapy, the radiation stuff is always a big deal for people up front, but there's a survival aspect on the other side. We want people to get back to normal life. We want them to not have to worry about going to umpteen number of doctor's visits all the time, and let them know that there potentially is going to be a time where they don't think about breast cancer every single minute of the day. And that's what we try to prepare them for as well.